Welcome to this video, where we present the results of our study recently published in Allergy, the first randomized placebo-controlled trial testing the efficacy of intramuscular adrenaline in histamine-induced hypotension. Anaphylaxis is a severe, potentially life-threatening allergic reaction. It can affect the skin, the airways, the gut. But the most dangerous manifestation is cardiovascular collapse. The cornerstone of emergency treatment is intramuscular adrenaline. Yet, no randomized controlled trial has ever tested whether adrenaline actually works in anaphylaxis. Current guidelines rely entirely on expert consensus and retrospective data. We set out to test intramuscular adrenaline in histamine-mediated hypotension. We enrolled 22 healthy volunteers. Using a continuous intravenous histamine infusion, we induced severe hypotension, mimicking grade 4 anaphylaxis. At 5 minutes, participants received intramuscular adrenaline or placebo. If blood pressure stayed below 60 millimeters of mercury, a second dose was given at 10 minutes. We first tested 300 micrograms of adrenaline in an open-label exploratory cohort, then confirmed with 500 micrograms of adrenaline in a double-blind, placebo-controlled crossover design. Here are the results. The blood pressure curves of adrenaline and placebo are nearly identical. Of 20 evaluable participants, only 5, just 25%, showed any transient blood pressure recovery. And even that was brief and not sustained. 75% did not respond at all. Here's the paradox. Even in the placebo group, the body's endogenous stress response produced adrenaline levels of 150 picograms per milliliter, already within the FDA's proposed therapeutic range. After adrenaline application, levels rose to nearly 400, far above the threshold, yet blood pressure stayed critically low. This means that current pharmacokinetic targets do not equal clinical efficacy. Even a second dose could not rescue non-responders. The overall difference between adrenaline and placebo was not statistically significant. About 2.6 millimeters of mercury on average, which is clinically irrelevant in severe hypotension. 3 key implications. First, the recommended first-line therapy for anaphylaxis needs careful reevaluation. Second, pharmacokinetic thresholds used by regulators to approve new adrenaline formulations do not predict efficacy during shock. And third, more potent and targeted alternatives are urgently needed. The full paper is published open access in Allergy. Thank you for watching.